Thank you very much for introducing me. I'm quite impressed. 158 participants. Hui. Thank you very much. Yes, quite exciting. Well, yes, I was asked to give a keynote lecture or I talk about the topic fertility. It's just the word fertility. And of course, the question is, what about fertility? And I think I will cover more or less how much cancer therapies affect fertility. I will cover the topic what to do to protect fertility or what to do if patients get infertile. You will see, I have 45 minutes, that's what I was told, correct? Yes. And let's see. First, a word about Fertility Protect. We just heard about it. The reason is I'm showing that because I will refer to this again and again because quite a few things coming from this network. It's a network founded 2006, and it's a Swiss, German, Austrian networks. In Switzerland, of course, we have a special situation, also a kind of commission called FertiSafe. Switzerland always has its own commission due to many languages, but it has 158 centers and is quite active in this topic. What I also would like to say, there is the book. I'm saying that the book is available in German, as you can see in red. It is free of charge and can be downloaded from the Fertility Protect website. If somebody wants to have a copy, a print copy, German print copy, please ask me. I still have 2 boxes because we found a company who printed 3,000-4,000 of these books. It's a second edition, and now the English version, the second edition is also translated into English. It's a very practical book, and you can really take it and then you find the information you need regarding infertility, what to do, etc., etc. Very practically orientated, written by people from Fertility Protect. This is our agenda: 4 topics: cancer incidences numbers, cancer and fertility, fertility preservation techniques, and future aspects. That's what I'm going to talk about. First of all, incidences numbers. You do know these numbers, I'm sure. But for this presentation, I went through all the numbers I could find for Switzerland as a representative country for the Western world, to be able to know exactly the number of cases which should be counseled here, which should be counseled elsewhere. That's why I did it, and I want to show you the numbers from my perspective. The age area we are interested in is this one, 0 to 39. And you see there are not that many cases regarding a comparison to older women and older men. Men are always in blue, women are in red. But quite a few, and I wanted to know how many exactly cases we have. But first of all, I would show you, of course, you know that the risk of dying of cancer has tremendously decreased by about 1/3 in the last 25 years. And that is a reason why this topic has become so important. That is a reason why this Cancer Survivorship Conference takes place. You know about this because now so many people survive, which is absolutely great. And it also affects us reproductive physicians. As I said, I wanted to know what kind of cases are behind these numbers. And I used the Swiss registry data, the Swiss official data from the institutes, from the administration, to see what kind of numbers we have. And as you can see here, we have between 0 and 39 years of age, we have around 1,000 men and 1,000 women being affected by cancer therapies per year. At the same time, we have 100 deaths cases, so most of them survive. 1,000 men, 1,000 women. You can use these numbers more or less for other countries. It's Switzerland, 8 million people. Germany, just multiply by 10. US, multiply by 40. So I think for the Western world, you can use these numbers for your country, and then you know exactly what kind of numbers you would expect. Of course, it's not only the matter of number, it's also the matter of diseases which are relevant. And that's why I created this table. I just want to show you the disease groups which are really affected by cancer, or which are really relevant regarding the topic fertility. That's the point. And you see, for example, the nervous system cases in relation to age. Yes, and what you can see is, I mean, these are glioma, for example. Not that many cases, but still quite a few cases, but most of them die. Not all, but many, fortunately. So unfortunately, so these cases are not that relevant for us. Doesn't mean we don't have to see them, but they're not that relevant for us. But for us are most relevant things like that, cases like that. Hodgkin's lymphoma, quite many, and almost all survive. Non-Hodgkin's lymphoma, according to the statistics, the same. Quite a few cases, most of them survive. The same here for colon carcinoma, rectal carcinoma. Many cases, more of them survive. And the same for males, testicular cancer. And leukemia is a bit, yes, it's a very special case because it's difficult to do something. So I wanted to know what kind of cancer patients we should actually see or we should take care of. Of course, there's a big group down here, other cancers, but other cases, but there's so many like sarcoma or osteosarcoma, which I couldn't really look at in detail. For women, it's more or less the same. Yes, I don't have to go through it, but breast cancer instead of testicular cancer, and breast cancer is extremely important, especially in these ones getting a bit older, but otherwise it is more or less the same. Colon, rectum, Hodgkin's lymphoma, non-Hodgkin's lymphoma, nervous system, as I said, unfortunately a low survival rate, and leukemia is a very special situation. So these are the cases which we are very interested in. To summarize, about 1,000 males and 1,000 females aged 0 to 39 years of age are diagnosed cancer every year in Switzerland, 8 million, so you can use this number to calculate the cases in your country. Most of them survive, therefore fertility is becoming an increasingly important topic. The most relevant disease groups regarding fertility are Hodgkin's lymphoma, non-Hodgkin's lymphoma, colon, rectum carcinoma, testicular cancer, breast cancer, but of course many more, but these are the big groups we have to take care of. Let's talk about cancer and fertility. How much does cancer affect fertility and how much cancer cases are actually counseled for fertility issues? And what I did here, I took the numbers for which we have quite good numbers, quite well-documented numbers from Fertility Protect, and I wanted to see if the cases counseled are more or less similar to the one which are really having cancer. And in Germany, it's just the same probably in Switzerland, 40% breast cancer, around 20% lymphoma, and then many other kind of cancers. And when you look at this, the numbers I have shown you before, breast cancer in reality, it's 37%, lymphoma in reality is 13%, and of course there are many more. So there is some discrepancy, but I was very much surprised there is not that much discrepancy, which shows us that quite people from all different areas, all different specialties are actually sent to be counseled for the issue of fertility, which I didn't expect. This is something which reassured me quite a lot. However, what did not reassure me is the number of patients being counseled, or the proportion of patients being counseled shown here. As I said, about 1,000, I'm talking about now females, 1,000 females, calculated for Germany multiplied by 10, it must be 11,000 females, but regarding Germany, you have 1,300 counselings. That means 1 in 8 women at the age of 0 to 39 with cancer are counseled, about 12%. Of course, please, we don't want to counsel 100%. It's impossible anyway, and it doesn't make sense to counsel somebody who has a very, very severe cancer disease and who will definitely die, or a leukemia patient who get a chemotherapy in the evening. But it should be a little bit more than 1 in 8. Yes, maybe 20, 30%, maybe 25%, but not 12%. So that's something we can work on. And it's the same situation in Switzerland. What is the risk of becoming infertile after cancer? I mean, that's overall. I mean, that's something we are very interested in and difficult to estimate the risk of infertility. There are more or less 2 studies, or let's say 2 approaches to look at this. This is a very new study published in 2021, and what they did in Canada, they linked the different registry and wanted to see what is the risk, the odds, the relative risk to become infertile regarding in comparison to those who are not exposed to a cancer therapy. But they only included those who had a 5 years recurrence-free time, and so who survived. And what you can see here is the relative risk to become infertile overall is 1.3. And you can see the differences of the different cancer diseases. Leukemia is a bit more. Hodgkin lymphoma, it's a bit more. Breast cancer is also quite a lot. We will look at it, why breast cancer has also a quite high relative risk. It's difficult to say what relative risk means, and I studied the study again and again, and it didn't really help me in practice, in clinical practice, these kind of data. But these are real data. You can use them. But the question is what to do with these data, and therefore this approach might be a bit better to get an idea what it means, fertility and cancer. And what they did here, they tried to find out the chance to conceive after a malignant disease adjusted for age, parity, and education. So this is the chance to conceive. On average, it's about there's a decreased chance to conceive of about 40% on average. Of course, in some diseases, it's much, much less. And I like this kind of analysis very, very much because this is the absolute reality. It's not only young people, it's also older people. So this includes everything, and we will look at it, what kind of factors are actually included in this. And this is quite impressive. I mean, 50% less chance to conceive. I think that's something which is relevant. And what that figure includes is this. What you can see here, a comparison of breast cancer and Hodgkin's lymphoma. In red, you can see the women who were diagnosed cancer, and then they were followed up if they conceived a child or not. And you can see that the breast cancer patient had a chance to conceive of 15%, compared to Hodgkin lymphoma patients of about 50%. In blue is the control group, they were matched, etc., etc. And what you can see is here what very much matters, the time. The reproductive time after cancer therapy matters very much. For children, you have lots of time. For young adults, Hodgkin lymphoma, you have a lot of time. For breast cancer, you're not having much time. The women are in their mid-30s, and that's definitely extremely relevant if a woman at the age of 37 gets breast cancer, gets the chemotherapy and endocrine therapy, and then she's 40, 42, and that's it. So that's something which is also included in these numbers which I showed you before. And of course, what else is included in these numbers is the intensity of the chemotherapy, and it's the age. The age relevance is also somehow included. And what you can see here, we have very good data about Hodgkin's lymphoma. You know, ABVD is a very weak chemotherapy, or less strong chemotherapy. BRCOP, especially BRCOP escalated, very strong. And the risk in young adults to become infertile, becoming amenorrheic, meaning infertile, is increasing, is higher in women getting BRCOP escalated. And of course, even more higher in those who are older. Extremely high, 70%, which is quite obvious if you have an ovary. This is females. If you have an ovary with not that many oocytes left, and you get a reduction of 50%, that matters much more as if you have an ovary with extremely few oocytes. That's why the risk is so much more, so much higher in older women compared to younger women, and especially in children. So the kind of chemotherapy in yellow and the age in blue matters, plus the time you have to reproduce yourself after the end of the chemotherapy. For radiotherapy, we also have very good data, and I just want to mention this. If you have it also depending very much on age. If you have a woman getting a radiotherapy of her ovaries, or in the area of her ovaries, she has a sterilizing dosage at the age of 10 of 18 gray, and at the age of 40 of just 7 gray. It's the same for chemotherapies. If there's not much left in the ovaries, then of course these therapies matter much more as in younger women. Okay, to summarize this topic, only in 1 in 8 women up to the age of 39 years with cancer are counseled for fertility preservation. I think it could be a bit more. In many types of cancer, the chance to conceive is reduced by 1/3 to 2/3, depending on the kind of chemotherapy, at the age, etc., after the cancer therapy. And the risk factors, as we said, is especially increased age at the time of the gonadotoxic therapy. For females, for males, age does not matter very much. As higher gonadotoxicity of the therapy and the few remaining fertile years after the cancer therapy. These are the main risk factors. So we learned that in special cases, special techniques, special chemotherapies, there's a low risk or is a high risk of becoming fertile. And when we want to talk about fertility, we have to talk about procedures which could be suggested, which could be applied to conserve somehow fertility. And these are the fertility preserving techniques. We have GnRH agonists in females, not in males. We have freezing of oocytes and ovarian tissue. We have freezing of sperm in adults, and we have freezing of testicular tissue in prepubertal boys. So these are the techniques, and I will just address these techniques briefly. But first, I want to say a word about costs. I mean, you're coming from all over the world, but I just want to say in Switzerland, we now have a reimbursement of IVF therapies. We apply to the Federal Office of Health with Tamara Diesch, with the Krebsliga. Krebsliga was a leading society which wrote the application, and myself. And yes, we were successful. And since 2019, we are very happy that the insurance companies cover freezing of oocytes, freezing of ovarian tissue, plus tissue transplantation, freezing of sperm, freezing of testicular tissue, and storage up to 10 years, but only if the risk of amenorrhea or azoospermia is more than 20%. I personally find this cutoff of 20% very good, yes, because we have to be very careful that we don't do an overtreatment in women or males. Males is not a big issue, it's easy, it's not that expensive, especially not in females, not to do an overtreatment to freeze too much. I mean, this might also be, any kind of treatment is a risk, and it might postpone the chemotherapy. So only those who have a relevant risk of becoming infertile should receive a fertility preservation technique. So I find this 20% cutoff quite a very good level. And the book which I showed you is more or less based on this 20%. We only recommend this if the risk is 20%. In special cases, of course, it might be a bit different, but 20% is, I think, is a very good number to work with. It's not reimbursed. GnRH agonists are not reimbursed, I think, more or less all over the world, because it's an off-label use. GnRH agonists are not labeled to do fertility preservation. So if a patient, this is for females now, for males it's so much easier. If a patient, a female patient, gets a chemotherapy, gonadotoxic therapy, then these flowcharts have to be followed to decide if she needs a fertility preservation technique. She needs to be young enough, less than about 40 years. She needs to survive probably, otherwise it doesn't make sense. The later pregnancy needs to be compatible with the health of the woman. What I mean is, if she gets a high dose radiation of her uterus, it doesn't make sense. The risk for the therapy, for the fertility therapy, needs to be quite low. Or now the risk of the cancer therapy to make her infertile needs to be at least 20%. And the risk of the procedure needs to be low. It doesn't make sense if you put the patient at very high risk to get a few oocytes. That doesn't make sense. So it must be quite a low risk procedure to freeze something. If all this is fulfilled, yes, then we can go down here to this list of techniques. If these are not fulfilled, all these criteria, or one of these criteria is not fulfilled, we should rather not do anything. I will quickly go through these different techniques which can be applied. GnRH agonists, I already told you, it's an off-label use, it's not covered, but the insurances in Switzerland usually covers it, but they could say no if they realize what you are doing, if they give these medications. The risks are almost none. It's a simple medication. We use it in gynecology, in infertility, whatever. It's a very common medication, and you don't have to worry about. Yes, we do have data regarding GnRH agonists that they do protect the ovaries, but we have only data about breast cancer. And we have only data regarding the short-term efficacy, let's say for 1 or 2 years after the chemotherapy. It was analyzed how many patients get a premature ovarian insufficiency, getting an infertility. And we have 5 prospective randomized studies, and overall they do show a risk of getting a POI, a reduction of the risk of getting a POI of around 50%. So we do have data in breast cancer, short-term data, that this medication does have an effect. And we even have data regarding pregnancies or in breast cancer, that more patients get pregnant if they got the GnRH agonist, but of course the number of events is low and there might be a bias, so we have to be very careful with that, but still this meta-analysis is around that it seems to have an effect. However, these are short-term data. We do not have long-term data, or we have very poor long-term data. We have long-term data regarding breast cancer. The blue ones got GnRH agonist in parallel to the chemotherapy. The control group did not get these medications. And what you can see, yes, the one who did get GnRH agonist have a higher chance incidence of menstrual resumption, but the difference is not very pronounced. So it's almost only a minor difference. difference. In Hodgkin's lymphoma, at the beginning, there was a difference regarding FSH concentration, but after 5 years, it's gone. So what I want to say, these medications are nothing for young people, according to data. They are not very effective long-term wise, and that's why they can be given to control bleeding. Yes, that's okay, a fantastic medication to control menstrual bleeding during the chemotherapy, but they're not the best medication, or they're no medication at all to protect the ovaries in young patients. There was a big discussion whether they're safe in hormone-sensitive breast cancer. Yes, they are safe. And as you can see here, this is the risk of getting a disease-free survival percentage in those who did get GnRH agonist and those who did not get GnRH agonist in hormone-sensitive breast cancer. It was exactly the same. So we are safe regarding this. To summarize, GnRH agonist, yes, they reduce the short-term risk in breast cancer for premature ovarian failure by 50%. We do not have definite long-term effects. It is safe in breast cancer, fine, but we do not have data for other cancer diseases. It's a simple therapy, why not? Because it also reduces the risk for heavy uterine bleedings. It is not reimbursed. It is an adjunct. It can be given, why not? But it shouldn't be the only treatment if the risk of becoming infertile is definitely high. What about ovarian stimulation to freeze something? Let's talk about oocyte. Ovarian stimulation to freeze oocyte. It only takes 2 weeks. It used to take 2 to 6 to 8 weeks, but nowadays we have protocols. We can start any day of the cycle. Very easy. Random start protocols, it's called. It takes 2 weeks. That's it. The risk is low. And very important, the success rate is the same. It's not impacted by the kind of chemotherapy. You could assume that Hodgkin's lymphoma, non-Hodgkin's lymphoma, has a chance to freeze oocytes or the number of oocytes might be reduced. It's not reduced. I know there are some studies around saying something different about Hodgkin's lymphoma, but it's a tiny, tiny difference only in Hodgkin's lymphoma, and it doesn't really matter. So stimulation efficacy is not impacted by the kind of malignant disease. But it is affected by the age of the woman, of course, we know that. And here, these are patients who froze oocytes from Fertility Protect, and you can see the oocytes which were retrieved and frozen in these women, around 12, 13 oocytes, but then it dropped when the woman was above 35, and even more if the woman was about 40. It's like in any kind of in vitro fertilization, the number of oocyte goes down, and the quality of oocyte goes down, meaning that as old as the woman is, as low the chance of the efficacy of this technique is, which is a bit of a pity. It's a tremendous bit of a pity that those who are extremely needing these techniques, of course, in these patients, it's not that efficient anymore. But that's what it is. In women up to the age of 35, it's very nice, but above 35, it's getting difficult. And that's what you can see here. We have 2 studies, yes, 2018 and 2018. Again, 2 different studies analyzing the live birth rate after using frozen oocytes before cancer. And what you can see, the live birth rate was 31%, 32%. So 1 in 3 women get a baby if they use their frozen eggs after a chemotherapy. One study, the COBO study, also analyzed the age dependency, and what you can see, the live birth rate in those who were about 31 plus minus, beginning of their 30s, was about 40%, and those who were at the end of their 30s, at the time when the oocytes were frozen, was about 30%. So it's also very age dependent. It goes down. But if the ovarian reserve is high enough, it's still quite efficient. But of course, as older they are, as lower the chance is. So in women at the age of 35 and less, the chance is 40% to conceive after using the oocytes. So to summarize, freezing of oocytes, it takes 2 weeks. Reimbursement in Switzerland is not given. The chance to conceive using frozen oocytes is around 33%. So 1 in 3 women will get a baby if they use their oocytes, or if they freeze their oocyte and they use the oocytes. The third technique in females is freezing of ovarian tissue. It's very exciting, but let's look at it into more details. The risk is low. It's a laparoscopy. It's a low-risk operation in normal patients, but in cancer, of course, we have to check it individually if the risk is increased or not. And here I just want to show you how we do it. Other countries like Denmark, they take a whole ovary out. Belgium, the same, they take a whole ovary out. Fertility Protect countries do what we suggested, and which is described in the book. We take 50% of an ovary out in 85% of cases. Very simple procedure. We just grab the cortex, we cut the ovary, or we take 50% of this ovary out. As you can see here, we wait a few minutes and we do a coagulation, a very, very precise coagulation of the small vessels. That's it. And this then is taken into the lab and it's frozen. Of course, if the ovary is very small or they get a bone marrow transplantation, there's a very, very high toxicity. A whole ovary can be taken out using stepless or whatsoever. Interestingly, the tissue can be transported. We get tissue from Basel, we get tissue from St. Gallen. In Germany, the distances are longer, so they use the overnight transportation. They transport tissue with these boxes. We have the same boxes, but they transport it overnight at 4 degrees Celsius and freeze the tissue, which is quite impressive, isn't it? I mean, oocytes are so sensitive, but oocytes are only sensitive if they have been triggered by LH or by the increase, by the LH surge just before ovulation, and they have resumed meiosis. Before they resume meiosis, they're extremely robust. I mean, women can get drunk, they can smoke, they can do what they want for 35 years, and they still fertile. The oocyte don't die. That's why it's so extremely robust to transport the tissue at 4 degrees for 24 hours. And what centers now even do is we do the same. If we get the tissue in the evening, we put it in the fridge, wait for the next morning, and then we freeze the tissue, which takes a few hours. So it can be transported, and it's very important that it's transported to a very specialized center. I'll show you in a minute. How to transplant the tissue? Well, there are different techniques. It can be either transplanted here into a peritoneal pocket. Here you can see this pocket, that's the ovary. So if this ovary is released and now it's just lifted, then it's lying exactly here where this small pocket is. So it's transplanted underneath the peritoneum. And it's the same patient, and then you can see this ectopic ovary, and the women can get pregnant because this ectopic ovary can be reached by the tubes. It can also be transplanted into the ovary. That's those one that the people in Brussels do a lot, in Denmark. Or it can be transplanted onto the ovaries, which the people in the US did quite a lot. This is by laparoscopy. Most people do a laparotomy. I have the feeling that this is the technique of the future. It's easy. Perfusion is perfect here. They can get pregnant spontaneously. I think that's a technique which will be adopted by most centers. But of course, there are many techniques, and we still don't know which is the best one. That's what it looks like 12 months later. How long, what is the longevity of the tissue? How long is the tissue active? It's very important. It doesn't make sense to transplant tissue to avoid a hormone replacement therapy if she became a POI. Not at all. It's just to get her fertile, to get her pregnant somehow. Here, these are the data from 5 centers in Europe, and we collected all these data, 280 transplantation, and you can see that the ovarian was still active in 50% of women after 5 years. It means here, she has to get pregnant here, but not here in the first few years. So transplantation means getting pregnant straight afterwards. And as young as a woman was at the time of cryopreservation, as high as the graft survival is. But of course, you see the tremendous heterogeneity for many reasons. We are just about to publish this, which tells us these are 196 cases of the Fertility Protect network, and which we were able to do to draw this diagram to show the chart.